Picture this. You've spent years wrestling with brutal period pain. Doctors finally stamp it with a name: endometriosis. Fast forward, you're pregnant at last, hearts are soaring, and then your OB drops one more line on the checklist. By the way, babies of parents with endo have a slightly higher chance of major birth defects. Your brain screeches. Wait, what? How much higher? Should I panic? Here's the thing. The data do show a rise, but it's a nudge, not a nosedive. Today, we're going to unpack that nudge, why it happens, how big it really is, and what you and your care team can actually do with the information. First, let's set the scene. Getting pregnant with endometriosis can already feel like threading a needle in the dark. Months of trying, maybe surgery or fertility meds, endless appointments. The last thing you need is a new fear monster under the bed. Research, though, is like turning on a nightlight. It doesn't make the monster vanish, but it shrinks it down so you can see what you're truly dealing with. So, what did this new Canadian mega-study find? In more than 500,000 births, babies whose parents had diagnosed endometriosis showed a small, but real, uptick in major congenital anomalies. Think of risk as a dimmer switch, not an on-off light. Endo moves that switch a click brighter. It does not blind you with stadium lights. Now, before we dive into the why, let's zoom out. Endometriosis is never the only character in a pregnancy story. Age, blood pressure, weight, family genetics, whether conception was spontaneous or through IVF, all those players crowd the stage. The study's numbers hand out probabilities, not verdicts. Picture a weather forecast, not a fire alarm. Your clinician reads that forecast and decides, do we pack an umbrella or do we cancel the picnic? Spoiler, we almost always just pack the umbrella. Okay, mechanisms. How could endometriosis raise the stakes at all? 1. Inflammation. Endo creates a hum of inflammatory chemicals in the pelvis and bloodstream. Early embryos are like tiny engineers building skyscrapers. If the construction site is smoky, some blueprints can smudge. 2. Hormones. Estrogen and progesterone signals run quirky in endo. Those hormones help sculpt the placenta, the baby's lifeline during the first critical weeks. 3. Immune quirks. Normally, immune cells shift into tolerance mode, so they don't treat the embryo as an intruder. In endo, that shift sometimes misfires, potentially nudging how organs take shape. None of these theories are courtroom-ready facts yet. They're puzzle pieces researchers are still clicking together. And here's an important twist. When the study removed pregnancies that used fertility treatments, the signal for higher anomaly risk didn't vanish. Translation? The condition itself, not just IVF drugs, holds part of the link. Still, many participants with endo were older or had chronic conditions. Those layers can stack, like turning up several sliders on a soundboard at once. So, what does this mean for an individual pregnancy? Yours, your sister's, your patient's? Imagine that studio sound mixer. Endometriosis bumps one slider. But age, genetics, blood pressure, medications, even smoking each have their own controls. Your healthcare team's job is to balance the whole track so the final song, your birth plan, sounds as smooth as possible. Here are 3 practical scenarios. Scenario 1. Mild symptoms, quick conception, otherwise healthy. You'll likely stick with routine prenatal care plus an extra careful anatomy scan around 18 to 20 weeks. Scenario 2. Long-standing disease, previous surgeries, maybe hypertension on board. Your provider might loop in a maternal fetal medicine specialist earlier and schedule targeted imaging of the baby's heart or kidneys. Scenario 3. Planning, not yet pregnant. This is prime time to lower background noise, inflammation, blood sugar, blood pressure before you hit record.
Think of it like a road trip where the weather app shows a slightly higher chance of rain. Do you cancel the vacation? Nope. You toss an umbrella in the trunk, maybe leave 10 minutes early, and keep driving. Action items you control right now. Ask whether your ultrasound plan should change. Review medications. Are any tweaks needed? Double-check folate intake, blood pressure, blood sugar, smoking status, whatever applies to you. And yes, talk feelings. Data is one thing, anxiety lives on a different planet. Let your team know what kind of info calms you and what spirals you. This research may also shift preconception care down the road. Clinics could start treating pelvic inflammation like background static, adjust meds, fine-tune nutrition, update vaccines. You get the idea. Earlier chats about family size and timing may also pop up so you can align symptom control with baby plans. Let that sink in. So, if you remember nothing else from today, remember this. These numbers aren't a brick wall. They're a gentle tap on the shoulder that says, hey, personalize the plan. So here's what we covered today. 1. The latest Canadian study shows a small uptick in major birth defects for babies conceived by parents with endometriosis, a nudge, not a cliff. 2. Possible culprits include inflammation, hormone quirks, and immune misfires, but the jury is still out. 3. The risk holds even without IVF on board, pointing the finger partly at endo itself. 4. Your overall risk mix matters more than any single label. Picture that sound mixer. Slide one knob up, slide others down. 5. You have levers to pull: extra scans, preconception tune-ups, lifestyle tweaks, and honest emotional check-ins. Now, what can you do this week? Jot down 3 laser-focused questions for your OB, REI, or midwife. Look at the actual numbers. Decide if you need a second opinion, more data, or simply a deep breath. Pick one concrete step, like booking a preconception visit, reviewing your meds, or setting up that anatomy scan, and put it on your calendar. You've got this. Endometriosis may turn the dimmer switch up a notch, but with the right plan and the right team, you can still light up the whole room.